Okay, so for those who haven't met me before, my name is Yahya. I'm a orthopedic registrar from London, from the UK. I'm going to be talking to you today about wrist and forearm fractures. So some of you have probably come to some of these sessions that I've delivered in the past, and you will know that I tend to ask a lot of questions and try and keep it a bit interactive. I'm sorry I'm doing it in English, not Arabic, but if you can, then obviously feel free to answer any questions. You can do it either in the chat, or if you want to, you can take yourself off of mute and you can speak if you like. I'll be asking questions quite a lot of the way through. Okay, so this is it's at a fairly basic level, this. And we're going to be talking about it from the very beginning, assuming that some of you are completely new to this topic. I know some people are more experienced than others, and we'll get to the more advanced stuff towards the end. But generally, we're going to make it so that everybody can attend, even if you are brand new to orthopedics, you can come and you'll still get something out of it. So, okay, so let's start off. Now, keeping it very, very from the beginning. So we've got a few bones in our hand and wrist that we all have to be on the same page about. You can see here that obviously we're not talking about hand fractures so much here, but everybody I'm sure will know that you have a radius, you have an ulnar, you have carpal bones, and you can see here that one that they have singled out is the scaphoid, because that of the carpal bones is by far and away the most problematic and commonly injured and very annoying to treat in some ways. We have a proximal radial ulnar joint and a distal radial ulnar joint, which I'm sure many of you will know already. The proximal radial ulnar joint is wrapped around and sort of created by this annular ligament and the very small articular surface between the top end of the radius that is completely round and then the corresponding very small area of the ulna that it articulates with. On the distal end, it's a slightly more complicated arrangement in some ways. Now, you don't need to know this in great detail unless you're sitting your FRCS exams or your boards in America. But this is what makes up your distal radial ulnar joint. It's a whole host of ligaments and a small articular surface as well that exists between the distal radius and ulnar. This is obviously there to create stability between the sort of the distal aspect of the radius and the ulnar, and it holds them together. And you've got your interosseous membrane that runs the whole length as well, and that is all designed to hold the whole thing together. And I think it's important that you all understand that your radius and your ulnar together more or less act as one thing. So although there is movement, they are one unit. One is affected by the other, and they create effectively a big ring. It's just that it's a ring that's been sort of squashed to make it look a little bit more like a sort of a flat hula hoop instead of a sort of a big wide open zero. But it is a ring, just like your pelvis is a ring. Usually you can't damage one part of it without something else being broken as well. There are a few basic movements that, again, we've all got to know. So people will talk about palmar flexion or just flexion, volar, palmar, they're interchangeable. Most people outside of orthopedics may talk about things in terms of palmar rather than volar, but within orthopedics, we use the term volar. It just means that you're going towards your palm. That's palmar flexion. Dorsal is more sort of unanimously called dorsal because we don't really have a name for the back of your hand, but it's important that we're all on the same page about that. So abduction can go either way, radial or ulnar. People will also use the term deviation, so radial deviation or ulnar deviation, to talk about sort of abduction of the wrist. Basics to do with X-rays. Obviously, we have a few different images here. The first one you can see on the left is an AP. of the wrist. You can see a lateral in the middle, and then you've got long arm views of the radius and the ulna as well in an AP and lateral. The ulnar styloid is a important structure to sort of be mindful of. Your radial styloid is obviously on the other side, and between there's the distal radial ulnar joint. You can see your carpal joints, your carpal bones, and all the joints associated with them, just distal to that as well. The lateral view, I would argue, is probably more useful to you when we're dealing with these kinds of injuries. And but I think for some people they find that to be the more difficult X-ray view to actually interpret. And the reason is that all the carpal bones are effectively overlapping, and it's very difficult to tell one from the other. But the first thing you need to do is know what can be accepted as a lateral X-ray and what cannot be accepted as a lateral X-ray. And when you're in theatre and you're trying to get an X-ray of the wrist and the lateral sort of position, the thing that will tell you that this is a proper lateral is being able to see the pisiform, which you can see here. It's just on the volar or palmar aspect of the hand, just there. Sort of, there's your thumb, can trace that down, and at the bottom, just lying underneath it, although they're on different sides of the hand, you'll be able to see your pisiform, which is it's sort of almost floating out separately. And the other thing to look for is that on your lateral, that your radius and your carpal bones are all aligned. So your radiocarpal alignment is a really important factor, and we'll come on to that in a bit more detail later. But you have to remember, of course, that your radius and your ulna are long bones, and just taking a quick X-ray of just the wrist, sometimes that's enough. But you shouldn't forget that that you can end up with more proximal injuries as well. And so getting good views of the entire radius and entire ulna is better, because that allows you to see that there is no injury at the elbow and that there is no proximal fracture, for example, things that are commonly missed. Now, outlined here, you can see what I'm talking about here in terms of the radiocarpal alignment in a bit more detail. Having a proper lateral view showing that you've got your radius with your carpal bones sitting directly on top of it, and then all of your metacarpals, again, directly on top of that, all in a row, shows you that the radiocarpal alignment is intact. Now, if you've got a fracture or a dislocation somewhere, or if you haven't taken your X-ray properly, then you won't end up with a straight line running up and down here. And that is important, because you have to remember that this is a pulley system, and part of the sort of the big issue around distal radius fractures and injuries around this area is obviously that they are often intra-articular. But the other big thing to not forget about is that there are tendons that span it on the volar side and on the dorsal side, and they are in balance, and they are a pulley system, and they have to be sort of roughly equal in tension in order to function properly. Now, if you have a fracture, that means that your radiocarpal alignment is not maintained and your carpal bones have shifted towards the volar side, then that balance is lost. Likewise, if it's all shifted towards the dorsal side, then that balance between the flexor and the extensor tendons is lost. We'll come on to that in a bit more detail later. So, but when we're looking at these X-rays, we have to know what normal looks like, and it is difficult to say that these values are reliable. I don't think that they are, but these are the ones from the textbook. And for any of you who are going to be asked any of these questions by your bosses, or at an interview, or at an exam level, then these are the kind of numbers that you need to know. All right, so radial inclination and radial shortening are things that you can see on the AP. The volar tilt is something that you'll see on your lateral, and the numbers that you need to know are all related to the number 22. So your radial inclination is supposed to be 22 degrees. Your radial height is supposed to be 22 millimeters, and then your volar tilt is half of that, which is 11 degrees. Which are not easy numbers to remember. Now, other things to look for are so these are just some images of the same thing on your actual X-rays. Now, I don't think those numbers are terribly useful because, you know, as more research comes out, and bear in mind that these numbers are very, very old and they're derived from papers that are quite weak and based on small numbers of patients, we're finding more and more that these numbers don't really correspond well to outcomes. So you have to know them, especially at a junior level, because people will ask you, but actually, I don't think they're very useful. Now, the way that I try to remember them is the book Catch-22, which is a common phrase, which basically just means that you're kind of damned if you do, damned if you don't, that you have no good options. And that's kind of what these things are. There are no really good options for looking at the AP or lateral films, and there are no good values. If you choose to use them, then you may find that they're not very helpful. Now, another thing that we commonly look at here is the so that all those values that we've previously talked about are all to do with the radius. Now, to do with the ulnar, the only thing that is commonly looked at, I would say, is the variance. Now, when we talk about ulnar variance, what we're talking about is the relative height between the radius and the ulnar. So when you take this AP shot, you can see that on the middle image, the radius and the ulnar are exactly level, and that's what we call ulnar neutral. So the variance is 0. That's neutral. Negative means that the ulnar is slightly shorter. Positive means that it's slightly longer. But you have to take this with a pinch of salt, as they say, which just is sort of an English term meaning that it may or may not be true. Now, the reason for that is that you might take an X-ray of my wrist and it could look like any one of those 3 images. And that doesn't mean that there's a problem. It doesn't mean that the radius has become shortened and I've had a fracture. It doesn't mean that I've been born with a congenital abnormality of my wrist. It's just that these are within the scope of normal. And I put that book there again at the top, just in sort of small font here, because again, the acceptable variance is within 2 millimeters. So 2 above or 2 below is still considered normal. However, it's only really normal if you X-ray the other side. So you could, for example, have a wrist fracture and your variance may be affected because your radius may be shortened. So they might look like they are ulnar positive, but in reality, that could either be related to a fracture or it could just be that they're completely normal. So it's acceptable to get an X-ray of the other side, the uninjured wrist, just to compare. If you really need to know, if you're really not sure, then you know, getting an X-ray of the other side so you know what their normal is fine. Now, the other thing which you obviously will be able to see here related to the ulnar is the distal radial ulnar joint, and if that has blown apart and the two are obviously apart from each other, then that's something else that you can see on that view, but that will be more obvious to you. If you don't look for the ulnar variance, you will not see it. So try to remember that book as just a sort of a memory aid, but again, I can't stress it enough. I don't think those values are really very helpful. Now, when we apply those sort of rules and those tools to this X-ray that you can see, would anybody like to unmute themselves and comment on this X-ray? Or you can write in the chat if you like. What can you see? Anyone who's feeling brave, they'll take themselves off mute. But I don't mind if you just write something that you can see in the chat. That's fine. Okay, okay, so somebody said a Colles fracture. Yeah. Okay, so Ahmed, you were the first person to come out with Colles fracture. So what makes this a Colles fracture? Because you're right, it is a Colles fracture. But what makes this a Colles fracture? What's the difference between what makes it a Colles fracture?
Extraarticular fracture
Mhm.
and dorsal angulation.
Yeah, absolutely. So a Colles is extra-articular and is dorsally angulated. Now, if we look at those same radiological parameters, now, can I ask you to actually apply any of those numbers to this? No, because how are you going to measure 22 degrees or 22 millimeters or 11 degrees? It's not really useful, is it? So I can't ask you to sit there with a protractor or a ruler and even measure, because also we don't know the magnification of the X-ray. But you are right. You said, okay, it's a Colles fracture because it's extra-articular and because it is dorsally angulated. Super duper common. We see them all the time. And on the lateral, I'd say that the more important thing here is not any of those degrees, not any of those measurements, but the fact that the radiocarpal alignment is lost. Now, this is a good example of where that goes wrong. So you can see here that the radius is obviously dorsally angulated, and that's at the level of the fracture. Fine, all right, we can all see that. But the thing which I think is quite useful to look at here is that the carpal bones are not in line with the radius. They are not sitting on top of it. It should be like a sort of a golf ball on top of a golf tee. It has to be balanced. Now, the problem with it in this situation is that now you've put all the flexors under tension and all of the extensors are slack. And so in terms of like the balance between the flexors and the extensors, functionally, there will be some loss. Now you can try to do the same thing with your own wrist. If you take your own wrist and put yourself into sort of dorsal extension and try and extend your fingers fully and try and make a fist, you'll find that there is a bit of a difference. The same goes the other way. If you flex your wrist up, I don't know if you guys can see me as well, but if you flex your wrist and then try and hold something, then your flexors don't work very well because all of your extensors are now tight. So that's sort of a common way that people talk about getting like a knife out of an assailant or whatever. Someone's trying to mug you. They say that you sort of hit their hands so that they're flexed towards the palmar or the volar side, because now you can't really use your flexors anymore. And the same thing sort of happens here in a way. Now, okay, so let's take that exact same X-ray and say this is your patient that you can see here on the left. And we think, okay, well, what are our options here? Now, you can see this patient is obviously older. She is maybe not very mobile. And what are the things that we need to know about that patient beyond that? How are we going to decide what our treatment options are going to be? Okay, I'll help you guys out. Unless anyone wants to write in the chat, I don't mind. Anything that you want to ask the patient or that you want to know about them. Okay, so I'll let you know. So this is obviously, as a Colles fracture, extra-articular. This is one management option that we can use. Okay, we can put it into a plaster, and in doing that, you need to know how to reduce it. And I'm sure that lots of you have probably reduced wrists in the past, but I will tell you that it's not as straightforward as just pulling the wrist. I'm just gonna put you on mute. Sorry. Okay, so it's not just as simple as just pulling it. I mean, you can do that, but you're not going to get a good reduction. The important thing is that you make it a bit worse first, and then you pull it, and then you sort of place the fracture on top of where it needs to be. And the reason you have to do it that way is to not disrupt the periosteum that will be on the dorsal side. Now, if you just pull it, you might be able to get the fracture back, but you'll completely destroy the periosteum that is remaining on the dorsal side. And in doing that, you're now going to make what was unstable much more unstable. And probably they'll need an operation after that. It won't stay on because there'll be nothing holding it apart from your plaster. Now, the important thing to remember about it is the reduction is very important, and that is their only chance at really avoiding an operation. And that when you're doing your plaster, you must make sure that you are following this sort of system. Now, you can see there are 3 arrows here. Does anybody know what those 3 arrows are supposed to sort of signify? Why are we applying force in those 3 places? There's a name for this. So this technique is called 3-point fixation. Now, the idea here is that you have to put force in each of those 3 places where those 3 little arrows on the plaster are. And if you don't, then the plaster will not work. The whole idea is that after you've put the fracture back together, you need force to be placed in those 3 places to keep it in position. Now, the way that a lot of people will sort of assess that is on the X-ray in plaster. You should be able to see that the plaster itself is compressing almost like basically against the skin, but only in those 3 places. The rest of it doesn't really matter that much. The rest of it can just be applied, it can just be put on. It doesn't need to be tight. But in those 3 places, you need to make sure that you've got plaster pressing on the skin, and that will allow the fracture to be well supported, because what it wants to do is go back dorsally. It wants to slip off backwards. And you're the only way that you can really prevent that from happening is by putting pressure in those 3 places. Now, the other thing we have to remember is that this wrist is likely to swell, and then it is likely to reduce in its size after that. So inside that plaster, it's going to need to have a bit of space to expand, and it's going to need a bit of room to do that in. So we don't put them in a full plaster on day one. I think in lots of countries, that is the norm. There are some places where they do that. But definitely in the UK, you will not find anybody with an acute fracture of their wrist or their ankle or anything where they are in a complete plaster. So it becomes a bit difficult to apply force in those 3 places if your plaster is just a back slab. So if you only have plaster just on the dorsal side, that's not really going to allow you to create that pressure from the volar side. So you need to have something there on the back, but you also need to have something on the front. So then I guess the question is well, where are you going to leave that little bit of plaster remaining? Where is that gonna where is that section going to be where there is nothing hard, where there is this sort of allowance for expansion? And for me, the place that I usually put that will be just along the ulnar border. So I take a sort of maybe a larger bit of plaster, drape it over the radius from the top, and leave the ulnar basically with no plaster on it at all, because the ulnar is not broken here. So there's no need to put it in plaster. And if you need pressure from the front and the back, from the dorsal side and the volar side, the only way of achieving that is if you have plaster going over the dorsal and the volar side. So you should have a strip where there's no plaster just running along the ulnar. And that means that you have room to expand, but you're also supporting it in the places that you're supporting it. Now, the common mistakes that I see when I see the emergency department taking care of these fractures is they will either just put plaster on the dorsal side, which I guess is okay, is quite common, but it's not great. Or sometimes even worse, they only put plaster on the volar side, on the palmar side, which is not going to do anything, because if you need support at all, it's to stop the fracture from slipping off at the back, not the front. So if you're doing these reductions in the emergency department yourself, I want you to give this a go. Next time you're there, I want you to take the plaster, make a little cut for the thumb, put it on the dorsal and the volar side, and then just leave the ulnar completely without any plaster. That will allow you a much, much better degree of control over the fracture and stop it from slipping off. Now, the other thing you need to remember is to keep that pressure on until the plaster is completely set. And if you do that, then it will at least stand a chance of holding the fracture in position and helping that old lady from avoiding an operation. So, okay, we've got the exact same fracture here, but we've got not an old lady who's sitting around knitting anymore. Now we've got this one who's breakdancing. So I guess the important thing we've got to remember here is that for these kinds of injuries, you are not just treating the x-rays alone, that you have to make sure that you see what the patient's activity level is like. Sorry, I've just seen a question. Is the cast position correct in the image? Well, I haven't actually shown it, but the position looks fine. I mean, I suppose in that, yeah, I mean, it's a cartoon, but yeah, it's an illustration, but it looks fine. I mean, the x-ray has, the x-rays that you take after the cast manipulation and plastering are totally vital, because without those, you're not going to know what you're doing. But yeah, I'd say that looks fine. So coming back to this one. So you don't have this old lady sitting in a rocking chair. Now you've got this breakdancing grandmother, and you have to be able to treat them differently. So the lady in the rocking chair may not get the same treatment as the grandmother, who's on her hands all the time or does loads of gardening. So the important thing is that you have to make sure that you speak to your patients, that you ask them questions, and actually determine what their activity level is. So I'll bring this back to you guys. So with this grandma, the one in pink, what do you think the treatment option that might suit her best might be? This is someone who, let's say it's her dominant hand, she's very active, obviously. Would you put her back in a plaster and not offer her an operation? Would you offer her an operation? What do you think? What are the considerations? Because I would argue that this patient is, even though if they're the same age, is a completely different ballgame. This one here needs a really good outcome. She needs the fracture to be completely perfectly reduced. That's the first thing. Whereas the second one, you know, even if the reduction isn't perfect, she might still be okay. But this one, she needs a good reduction. And this might be better for her. So with a Colles fracture, the benefit of fixing it with what we call K-wires, Kirschner wires that you can see here, is that it's a bit more reliable, and it allows us to have a little bit more security, knowing that there's something keeping the fracture in position. Now, look, you could treat both with a plaster, but I would argue that the plaster, when you see it again, when you see that same patient again in 2 weeks' time, or even longer than that, it may have slipped off. And the reason will be because the swelling has gone down, the plaster doesn't fit properly anymore, it's not been doing anything for a long time, and now the fracture is hanging off. And are you going to operate at that point? No. So I think that for someone where you really need them to make sure they get a good outcome and it's still extra articulate, this is a better option. Now, these are done percutaneously. It's usually a pretty short operation. People who do these quite frequently will tell you that they are quite straightforward, but it's about patient selection. This is a extra articular fracture, and so K-wires are perfect. There are a few things that you need to avoid when doing this kind of operation. And so although it's percutaneous, you do need to make a cut in the skin, and you do need somebody to protect the soft tissues. There are a few things that are at risk, particularly the superficial branch of the radial nerve, which is perfectly placed to be injured by the K-wires that you put in from the radial styloid. And then also there's another wire that comes in from the lunate fossa, which comes in from the dorsal side. And that is the one that you can see running perpendicularly to that. And that has a good habit of catching the extensors. And I will tell you, categorically, I have definitely seen many surgeons take the wire, put it through the skin, and then just drive it without making a cut in the skin at all. I have seen that, but it's not the right thing to do, because you might be lucky, 99 times, but that one time in 100 where it captures all the tendons and creates a mess, it's not worth it. I have seen patients come back to theatre to have explorations of their tendons for this reason. I have seen patients who've lost the sensation from their superficial branch of their radial nerve from that kind of thing. So if you are going to do these, if you are in a unit where they do this a lot, then just make sure you're making a small cut in the skin and you have somebody with some retractors to make sure that when you put your KUR on the bone, that you're not catching something on the way. So what about this then? So different fracture, different pattern. Would anybody like to comment on the X-ray at all? There are big white arrows that show you where the problem areas are. So let's start with the AP X-ray. What can you see on the AP that tells you that this is nasty? So what were the parameters that we were looking for? I don't want you to tell me numbers, because I've told you a few times that I don't care about 22 degrees or 22 millimeters or any of that stuff. But is the radius shortened? Yes. What else can we see? So there was radial height. There's the radial inclination, which is the sort of the angle at which it takes off from the ulna towards the radial styloid. So that's been lost. It's totally flattened. I'll make it a bit easier. Does this look better or worse than the previous X-ray to you? Exactly. So this is intra-articular. This is much worse. This is comminuted. You can see on the AP that this fracture is a bit more distal. It extends into the articular surface. But the thing that really tells you that this is a bad fracture is the lateral. So you can see that there's this big step here, which this white arrow is showing you on the lateral view, that shows you there's a massive gap in the articular surface. You can see that the fracture fragments are really displaced. You can see that there is dorsal comminution, which the other white arrow on the lateral is showing you. And all of those things tell us that this is going to end really badly if we leave it alone. What is the thing that we expect to happen here? If we do nothing and we just put them in a cast and say, okay, see you later, take the cast off in 6 weeks, bye, what is going to happen to that wrist? Okay, I'm going to start telling you guys the answers because it's maybe a bit slow. But okay, I'll describe the X-rays to you. On the AP, you can see that it's very comminuted. It's a distal radius fracture. You can see that it's shortened. You can see that the radial inclination has been lost and the radius is flattened. You can also see that the ulnar variance is very positive. The ulnar is straight up in the air. The distal radial ulnar joint also looks like it's affected. On the lateral, you can see this intra-articular step, this gap widening. You can see displacement of the fracture fragments, the comminution I mentioned. But the really vital thing here is twofold. The articular surface is not intact, because on the AP it doesn't maybe look that bad, but on the lateral it looks terrible. But the other thing is the radiocarpal alignment is not maintained. Now we've had some answers. Shortening the rib determines the pronation and movement and supination. Yeah, so I think you're getting to the right sort of answer. If we leave this alone, what will happen is this patient will develop horrible arthritis. They will have a lot of stiffness in that wrist, and they will definitely lose some pronation and supination, but they will definitely also lose some flexion and extension at the wrist. And if you keep them in a cast for 6 weeks and don't get them moving at all, they'll probably be quite stiff in the hand as well, and probably also the elbow if they've been in a sling the whole time, maybe the shoulder as well. So there's a lot to think about. Now, I think that the key thing about this X-ray, however, is not so much the x-rays as I think it is what your options are and what you might do with the different kinds of patients that you have. Now, this is a treatment option. And you obviously can see here that this has been fixed with a plate and screws. It's all been restored back to looking completely perfect. And you can see here that they've marked out these radiological parameters to show you what a great job they've done. You know, A, B, and C are the different radiological markers that we've been talking about. And that looks great. Okay, fine. But are you going to do that for every patient? Well, I would argue that this is not the right treatment for everybody, but it is the right treatment for somebody. Now, you've probably seen some of these plates in real life, but I'm just going to tell you briefly about them. Now, you can see here that they come in different sizes, different shapes. But the key thing that these all sort of hold in common is that there's been a gradual sort of evolution towards more of these ones on the right and less of these ones that you can see on the left. Now, the ones you can see on the right are a typical distal radius volar locking plate. You can see here that it's got all of these funny shaped holes on the distal end, and on the proximal end, they look quite different. It's also got these tiny small holes that are for K-wires to go through, and these are to help guide your plate into the right position and to show you where the screws are going to go when you put them in as well. Now, locking plates, we've talked about when we were doing the ankle fracture lecture, but I'll just tell you briefly about why they're beneficial. Now, these are intra-articular fractures. And so just to remind you guys, I'm sure that you probably were, maybe some of you were in that lecture, maybe some of you weren't, but intra-articular fractures need to be held absolutely dead still. They need to be reduced perfectly in order for you to avoid getting lots of callus. So absolute stability and an anatomical reduction are the things that you need. Now, a locking plate can help you achieve that because, as you can see here, when they try and pull the plates off, they behave differently. They behave differently if they are locking versus non-locking plates. Now, on the left here, this is a locking plate. All of those screws actually articulate and lock into the plate itself, so they become like one thing. So the plate and the screws all are just one thing. It's like an internal external fixator. It's like an X-fix. It's locked. It's all one big structure. And if it's going to fail, the whole thing has to fail in one go. So these are much more rigid. Now, on the right, you can see a non-locking plate. And if you try to pull that plate off and sort of force it to fail, the screws will fail one at a time. And you can see here that they are not all acting as one piece. They're all acting as separate pieces. These are four structures that are just held together by the fact that you've tightened the screws down. But actually, it's relatively loose. The only thing that's sort of keeping it all together is the friction against the bone itself. Now, the benefit of a locking plate is that they will manage to grab each fragment and keep it all completely perfectly aligned. The downside is that they are expensive, and they are technically probably more difficult to apply than non-locking plates. But it's not really an option to use a non-locking plate in the distal radius for an intra-articular fracture like this. You really do need it to be held absolutely stable. And the reason is that if we are going to do an operation and commit, then at least it should be for a point. And the point is to stop them getting arthritis. That's the whole idea. So, okay, so that all seems fairly simple, right? We're talking about radial inclination, radial shortening, and volar tilt as our radiological markers. The ulnar variance and the radiocarpal alignment, I would say, are the two things that you really need to make sure you look for. But there are a few more complex situations. So extra-articular fractures, we've talked about a little bit. Intra-articular fractures, we've talked about a little bit. And we've mentioned that it's important to tailor your treatment to the patient. You have to make sure you actually speak to them. So plaster, wires, or plate are all options. But now we're going to take it to some cases that we're going to sort of step up the difficulty a little bit now. So you're all familiar with these, and I want you to keep these in mind as your options A, B, and C for the next few cases, okay? So this is a case. That's what you see in picture A. B and C are your AP and lateral, the same patient. And I want you to think about what those different options are for this kind of patient, and what kind of things you're going to do in the emergency department straight away. So I'd like you guys to answer in the chat, and I'm just going to ask you, in this situation, with this being an 82-year-old female patient who's had a fall at home, what else do I need to know? If you can just put one question up that you think is the most important thing that I need to ask them and I need to know. And that can be part of the history, it can be part of the examination, anything. I've been told by the emergency department to come down, and they've sent me these x-rays and said, okay, this is the patient we've got. And I get there and I can see that this is the risk that I've got in front of me. What is the first thing that I should do? Top priority for any fracture, anything in orthopedics. What do you think the first thing has got to be? So first answer we've got here. So the reduction is important, and relieving the pain is important. But the key thing that you've mentioned there is restore perfusion. Now, it's not that that's wrong, but before doing any of that, you really need to check and see, is this patient neurovascularly intact, i.e., are their nerves and their blood vessels working properly? So that means checking the capillary refill in the fingers. It means checking the temperature of the hand. It means checking that they've got sensation in the radial, ulnar, and median nerve distributions. It means checking that you know their flexors and extensors are working. Now that doesn't mean that they should be able to use the hand completely and grasp you, you know, like a weightlifter. But it does mean that you need to check that at least the sensation and the blood vessels are working. But you're right. If there's an issue with perfusion, if there's an issue with the sensation, then yeah, reducing it will definitely, you know, be the first thing that you want to do. It's the first thing that will help with the pain and restore the neurovascular status for sure. The other thing I would argue that you need to do is make sure you look at the whole hand, because you need to make sure that it's not an open injury, because that changes our treatment completely. What else do I want to know? So let's say it's neurovascularly intact, and I've now reduced it and taken care of their pain. What's the next thing? Can anybody else come up with any other bits of information that I need to get from their history? Imagine it's a real patient in front of you in the emergency department. So they're neurovascularly intact. Okay. I've put them in a plaster. Okay. The pain is better. Okay. That's all good. I've checked the capillary refill in the plaster, and their sensation is all fine in the plaster. Okay. What else do I want to know? I want you to imagine that your grandmother, who's 82, has fallen at home. What do you think the first thing you're going to do if you find her on the floor is going to be? Because I don't think that you guys would jump straight to the wrist. I don't think that you would go and just check, oh, has she got a wrist fracture? Accompanying diseases, for sure. You need to know what their past medical history is. That's a good question. What I'm getting at here, I mean, that is 100% true. You're totally right. But you need to make sure they haven't got any other injuries. 82 female, they will definitely have osteoporosis. They will almost definitely have other diseases that they show up with. I don't think you'll find many 82-year-olds who have a completely clean past medical history. They will all have some problem. Smoking history, medications, these things all matter. So their neurovascular status has to be top of the list. You have to check that they have no other injuries. And I would actually argue that depending on how they hurt themselves and what the situation is like, you might even need to follow a sort of ATLS protocol. You need to make sure that this is not just one injury amongst 10. Their past medical history has to be checked. You have to know if they're a smoker, but also their hand dominance as well, because that changes your treatment strategy for some of these patients. It changes what you do. You know, I mean, if it's that breakdancing grandmother, or if it's the knitting grandmother in the rocking chair, you might change what you do. So this is one option, and we've talked about that one before. So in this kind of situation, a plaster may seem like it's just fine. Now that X-ray showed a totally smashed up wrist, but in the context of someone who is not a weightlifter, not a manual laborer, not a breakdancing grandmother, that is not that is not going to be a problem. Even if you lose the reduction, it's still going to turn out just fine. They might have a bit of pain, they might have a bit of stiffness, but if they have a big significant past medical history, then you really want to avoid an operation as much as you can. Most of these cases, you know, will come in with X-rays that look terrible, and you shouldn't be put off by that. If it's someone who is in this sort of demographic, you don't need it to be A-star perfect every time. You need it to be good enough that they can carry on with their life, but it definitely doesn't need to be perfect. So, okay, exact same X-rays, exact same picture, but this time it's a 28-year-old and they've been in an accident. Let's say this is someone who's come off of a motorbike, and they've come in with the exact same X-rays, exact same looking wrist. Now, what do you want to know? The questions aren't really very different. So what's the first thing that you need to know? Bear in mind it's a road traffic collision. You have to know if they've got other injuries. 28 with a smashed up wrist that looks like that, that's a high energy injury for a young patient. And so the key thing is, do they have any other injuries? And is this limb at risk? So neurovascular status. This patient doesn't have a past medical history. They're a non-smoker. They are left-handed, but they're a guitarist. So for them, this left hand that they have is the really important hand for them. This is the one that they use to pluck strings and make their money. So what do you think the treatment options here are going to be? Obviously, you're going to put them in a plaster because, as one of you guys mentioned before, this is a patient who is not going to get an operation today. Fine. So X-fix, it's actually not a bad suggestion. So an external fixator has been suggested here as a possible treatment, and I would say that's actually quite a good option. It is certainly one. Another option is something like this. So this is a sort of an internal X-fix. This is a spanning wrist plate. Now, this is not designed to completely anatomically put back all those little pieces together, because it's just not possible. You can't do it. And this is also not designed to necessarily stay in forever. This is a plate that is usually just temporary. You can use it permanently for wrist fusions, but we're not talking about that in this context. This plate for this injury is a temporary thing. And the whole idea is that bag of bones that we've got in that distal radius that cannot possibly be put back together anatomically, we leave the periosteum completely alone, and we hope that when we pull it out to length, that the periosteum will sort of help it to look like a wrist again. All you're aiming for here is radiocarpal alignment and length. That's it. This is a sort of an operation of last resort. Now, using an external fixator would achieve the same thing, the difference being that you end up with this sort of big structure outside the wrist, and there's a higher risk of getting pin site infections and complications. Also, people are not maybe always that familiar with X-fixing around the wrist. I can't say I've done it many times. The time when you might use an X-fix is actually if you've got an open fracture. So an X-fix in that context, definitely, because you need the skin to be left alone, more or less. You need to be out of the zone of injury completely. This, as an internal fixation, this does require a small cut, beyond and proximal to the injury, but it's not a lot. And you can slide this plate underneath the skin. It doesn't need to be sort of exposed like an external fixator would be. It definitely doesn't need a full exposure. All you're doing is making sure that you are under your extensor compartments and that you're sliding the plate, and that's it. Once the fracture's healed, you take these things off and you try and get them moving, and you just hope that the bones have sort of turned themselves back into something that looks a bit like a distal radius. But it's of course not the best option, not by a long way. But if you were to try and open that thing up and use a normal distal radius locking plate, it would fail. There'd be almost no point. And the thing you would do in trying to do your best and fix every single little piece is you would end up basically devascularizing the entire area. You'd have to end up stripping off periosteum where you don't need to. The best thing you can do here is do as little as you can to the periosteum. So you're leaving it alone completely, allowing the blood supply to be unviolated so that you hope that it will just all heal back together. So we talked a little about X-fixes, and this is the sort of situation where you might need one. This is an open injury. Now, what else can we see about this fracture? What's going on these X-rays? Well, let's start with a few questions. Is this just a distal radius fracture? Obviously, it's open, but is this just a fracture of the distal radius? I'm kind of hinting that it's not. So there is an ulnar fracture here as well. They're at the same level. And so this is really unstable. What else is different about this injury? What do you think the age of this patient might be, roughly? Does this look like an old person? Yeah, they're young, because you can see growth plates here, right? So here you're looking at an open fracture in a pediatric patient. This is a really terrible thing. This is something that you hope you don't see, right? So you can see here that the growth plate has been violated on the radius itself. Now the ulnar is away from the growth plate, fine. But what's the big worry here? In any young patient, what's the thing that can go wrong if you mess this all up? Infection is definitely a problem in any open fracture. However, not so much in the upper limb. In your tibia, your ankle, definitely. Anything below the knee, if you have an open fracture, which is by far the more common place to have one, right? If you've seen open fractures, 9 times out of 10, it's almost always below the knee, right? Fine, we know that. You can obviously get them anywhere, but we hardly ever really see them in the wrist. We always see them in the ankle. We always see them around the tibia. But actually, in the wrist, they don't tend to really need quite as much of a aggressive treatment as in the tibia. However, nonetheless, infection is still definitely something you need to think about. You are absolutely right. The other thing that you've mentioned here is continued growth, right? So if we don't get this right, and this patient ends up with a malreduction or a complete destruction of their growth plate, then they may end up with an ulnar that continues to grow, but a radius that doesn't. So they may end up with a deformity that continues to develop as they continue to grow, because their growth plate at their distal radius may not work at all anymore. But if their ulnar is still working, then the ulnar will keep getting longer and longer. So what radiological measurement is going to end up being seen later on in life? Well, it'll be their ulnar variance. Their ulnar will end up really positive, pushing up towards all of their carpal bones, and they will end up with radial deviation of the wrist as it heads towards the thumb, right? As it heads towards the radius, because now the radius isn't working properly in terms of growth anymore at all. So in this kind of situation, an X-fix is a good shout. Okay, and X-fix works well here because here you really need to quite kindly debride, wash out, and close that injury. If you really need to, then you can obviously always involve plastics or vascular if if it's a more complicated open fracture. But in terms of your orthopedic input, you need to make sure that the wound is visible to someone on the ward afterwards. You can't just fix this and put them in a bandage or put them in a plaster. You also do not want to have any metal work in and around that open wound, because if you look at where that is, that's exactly where you would normally put your incision. So it's exactly where you don't want it to be, right? So if you put a metal plate in there, okay, fine, your x-rays might look spectacular. You may have the best looking x-rays ever, but it's not going to be much use if it all gets infected. So in this situation, an X-fix is definitely the right answer. So what about if you've got a patient who looks like this, sort of teenager, younger, maybe sort of, late teens or early 20s, something like that, falling off a skateboard onto an outstretched hand. Now, this is kind of the same mechanism that you get a Colles fracture in, but in this younger patient, what's the thing that's more likely to be seen? Because you won't see a Colles fracture. I'll tell you that. What's the most likely injury that I'm going to see on the X-ray? Scaphoid fracture, exactly. In this age group, a scaphoid fracture is what you're going to find. Now, what is the big deal with scaphoid fractures and why are we so worried about them? And I think you probably know, but let me ask you, what makes a scaphoid fracture so different to all these other fractures? What makes a scaphoid fracture so tricky? Because it's nothing like a distal radius fracture. What is the big deal? Non-union, exactly. And the reason why we get non-union cases is because the blood supply is really bad. Now, where you have your fracture in the distal in the scaphoid does matter. So you can see here the broad ways that we kind of categorize them is as either a distal fracture, a waist fracture, or a proximal fracture of the scaphoid. And that matters to us because your non-union rate changes depending on where your fracture is. Now, the blood supply you have to know, and just simply, it comes in from the top and works its way backwards. So it's a retrograde supply, and that all comes off the radial artery. Now, that retrograde supply means that the blood supply at the proximal end is not as good as it is at the distal end. So if you have a fracture that happens at the distal end or at the waist, we're not really that worried. But if you have a proximal fracture right at that tip, just where it sort of starts getting towards the radius itself, just at that tip, there's almost no blood supply, and the chance of you getting a non-union in that area approaches almost like 100%. The more distal you go, it ends up in the high 90s percent-wise. So what are our options? Okay, so first thing you can do is you need to tell them to stop smoking, because non-union is so much more common with cigarette smokers. And even these young patients, a lot of them will obviously be smoking. So the first thing that you need to do is tell them, you need to stop smoking, your parents need to stop smoking, you need to not be around smoke. Smoke is the devil. Smoke and non-union are closely aligned in their objectives. The other thing you need to do is obviously put them in a plaster. And there used to be a real tendency to plastering all the way up and including the whole thumb. But actually, it's not necessary. The part that you need to plaster is up to and including the first metacarpal, but the thumb itself should still be free. So everything from the thumb MCPJ onwards should be available for usage. There's no benefit in keeping a patient immobilized unnecessarily. Now, if this is their dominant hand and you plaster all the way up to their nail, then they're not going to be able to use that hand at all. Their thumb will be useless and they hate them. They often end up even taking them off. So it's important that when you plaster them, you are plastering them correctly and safely, but not more than is necessary. Now, the other thing that you can do here is ask them to take vitamins. So vitamin C, why do I want them to take vitamin C? Because bear in mind, this patient is going to be in plaster for quite a long time. What does vitamin C help to prevent? Does anybody know? If someone gets the right answer to this, I'll know that they've been doing orthopedics for quite a while. I'll know that they've actually been in clinic with hand surgeons and wrist surgeons. Has anybody heard of CRPS? So complex regional pain syndrome is a major problem with fractures of the hand and the scaphoid. And the reason for that is not fully well understood, but what it essentially is a strange syndrome where patients end up with more pain than you would expect them to have and more stiffness and swelling than you would expect them to have. The risk factors for it are, they tend to be that you've had an injury in the hand or the carpals, and that you've been in a plaster immobilization or had some kind of surgery and ended up sort of traumatized by not only the injury, but also the surgery, and then left in plaster for a long time. These patients really struggle to get their movement back. They become so hypersensitive to pain that even just a light touch on the skin is unbearable for them. And so I usually will start them on a high dose of vitamin C from the emergency department. It's the first thing that I'll tell them to go. Once the dust has settled and they're going home, I tell them go and buy lots of vitamin C, and you need to take it every single day. The other thing is vitamin D. Now, vitamin D is probably a more obvious one. Why do I want them to take vitamin D? Vitamin D is the obvious one. You guys will all know it. It even says it right on there. It helps with your bones, right? It's what they're made of. So vitamin D is important for the import of calcium and calcium homeostasis. And being on vitamin D is helpful for avoiding non-union. So we've had a question here, which is, what is the dose of vitamin C exactly? There isn't really a maximum dose, and there isn't really a minimum dose. Vitamin C doesn't have a maximum dose. The supplements that you might buy in the pharmacy will tell you to take 1 a day. And in these kinds of fractures, I usually tell them to take 2 or 3 a day. But that's just me making it up. That's not based on science as much as it is just, my own experience and seeing what people more experienced than me do. But there is research out there on it, but I don't think we really know. But a much higher dose of vitamin C than is recommended is the way to go. The other treatment option, if that fails, is obviously fixation. And you can see here 2 small images of screws. Now, these screws are specially made for this kind of fracture, and they are designed to compress and stabilize the fracture itself. Now you can see that there's a big X drawn over one of them. So what is wrong with that image that you're seeing on the right-hand side? Why is there an X on one and not on the other? What is wrong with that screw? You can see it in the picture. So we need this to compress, right? Without a reduction and at the actual force of compression happening across the fracture site, it is not likely to heal. And all you will have done by putting that screw in is hold them apart. You're not even allowing them to find their way back together. So you need it to look like that image on the left, because on that image, you've got thread on one side of the fracture and then the screw thread on the other side of the fracture. But then between them, there's nothing. There is no thread actually crossing the fracture site. And that means that when you tighten it, it will start to pull the two things together. Now, why does that work? It works because the screw is designed with a different pitch on one side and a different pitch on the other. Now, that means that when you turn it, one side of the fracture will move and the other side will move much, much more. So here, every time you turn that screw, the distal part will not advance very much because it's got a very short pitch on the thread. So every time you turn it, the screw will not really advance much in the distal part of the fracture. But in the proximal pole of the fracture, the bit where those two green arrows are, that has a much longer pitch. And so every time you turn that screw, that will advance the screw a lot more. And so that means that you're pulling the two fracture fragments together and compressing them together. And it's the force of doing that really allows it to avoid non-union. Now, the reason why that other screw is not correctly placed is because the thread is still crossing the fracture line. So all that is doing is holding the fracture apart. It's not compressing anything. It's actually doing the opposite. It's keeping it apart, which is not helpful, obviously. So this is kind of what your X-rays end up looking like. And I would say that one of the difficulties with scaphoid fracture fixation is getting good X-rays and having an experienced assistant. It makes that much easier. But you're the person getting those X-rays in theatre, and it is quite tough. The thing that is a good marker for healing is actually when you get down to the fracture, what you can do is take a K-wire and just drill just slightly into the non-union itself. And if you find that it's got what they call punctate bleeding, where you just get a tiny little bit of bleeding everywhere that you've been drilling, that's a good marker that it has a blood supply, and that all you need to do is reduce it and compress it, and it will likely heal. But if there's no punctate bleeding, then that bone is dead, and it's not going to heal. And so you can try, but it's not going to heal. So what do you think the option would be in that case? So that bit of bone is dead. Now, anywhere in the body, the same principles apply. If you're trying to get a bone to unite back together, first thing it has to do is be alive. It has to have a blood supply. So you just have to take out that part that's gone, that's dead, and you need to put in some graft. So that's the situation where graft is required. Now, scaphoid fractures are a whole other lecture all on their own, and they do get quite complicated. But long story short, you need to recognize them because they're often missed. You need to know how to treat them in different kinds of patients. And you need to know that in the younger patient, these kind of adolescent, late teens, early 20s, you're not going to find a distal radius fracture. You're going to find a scaphoid fracture. And if you don't examine for it and look for it, they're very, very easily missed. And they're actually, in the US in particular, where there's lots of litigation and lots of lawyers involved in healthcare, they're a major source of legal success for patients to sue their doctors. And the same is also true to some extent in the UK. And part of that is because they turn out so badly. And part of it is because they're in such young patients, and they often are on the dominant hand. Because when people fall, quite often they put out their dominant hand, and that's the one that they use to try and sort of break their fall. So the issue with scaphoid fractures is they're often missed, delayed presentations, poorly managed, CRPS, failure of surgery. All of these are problems. And the best thing that you can do is recognize it and choose the right treatment for the right patient. The thing that I personally find is that often they're not told about the smoking, they're not told about the vitamin C and the vitamin D, and those are things that cost absolutely nothing. All you have to do is speak to them. All you have to do is tell them, you need to stop smoking, you need to start taking these vitamins, and it can really be helpful in avoiding these major sources of being sued and poor outcomes and the need for further surgery and even worse outcomes as a result of that. So when I say these are all tricky ones, scaphoids really are on a different level. They are very, very difficult. So what about this patient? So a little bit younger. So in this kind of patient, they won't tend to get a scaphoid fracture, and they won't get a distal radius fracture so much as they might. I mean, sometimes they will, but the thing that you sometimes see in these patients is actually a both bone forearm fracture. Now, these are, again, a sort of, they're treated quite differently in some ways to other long bone fractures. Now, you'll remember right at the beginning of the talk, one of the things I said is that the radius and the ulnar and their pronation and supination sort of relationship means that they are effectively almost like one big intra-articular sort of bone. They are one unit. It's a ring. And the whole thing has to work together. Otherwise, you will not be able to do that complex movement of pronating and supinating. And pronation and supination is really important for functional day-to-day tasks. If you are having to use a computer or a mouse, you need to be able to pronate. If you're trying to use a screwdriver, you need to be able to supinate. And you can live without it, but it's quite disabling. Flexion and extension of the wrist, you can lose that and still be pretty functional. You can still manage to get by without flexion or extension of the wrist and just in a neutral position, and you'll be basically okay. But you won't be okay if you lose pronation and supination. It really is, it's a different ball game completely. So why is that important? Okay, so what are the things that can go wrong here? You can obviously end up with stiffness. You can end up with deformity. Now, it's worthwhile remembering here that the ulnar is pretty straight, but the radius has a bow to it. And that bow is the thing that allows it to rotate around the ulnar. When you pronate and supinate your wrist, what you're actually really doing is rotating the radius around the ulnar. The ulnar stays still, more or less. The ulnar just sort of stays exactly where it is. Now if you think about where the ulnar goes at the elbow, it can't rotate, right? It's locked in at the elbow to be in one rotation because it has a whole big elbow joint that's holding it in that position. So the ulnar does not rotate. But if you remember, the radial head is circular, right? And that rotates. So it is the entire radius that twists around. And if the radius is completely straight, it will not be able to do that. So you need to have a good reduction of the radius, a good reduction of the ulnar. Otherwise, that movement is completely lost. Now, the other thing to think about here is the level of the injury. So you can see an X-ray here, and you can see that the radius and the ulnar fractures are at exactly the same level. Does anybody know what kind of problems you can develop as a result of that? I'll tell you that it's very unstable. That kind of fracture is really unstable because both fractures are exactly the same level. Just like if you fracture the tibia and the fibula at the exact same level versus at different levels, they behave differently. So with this kind of fracture, what kind of problem can you develop? It's a bit of a weird thing. You either kind of know it or you don't. When they're healing, what can happen? And it's a major problem when it does. A bone bridge. So you are exactly right, but it has a proper name and it isn't bone bridge, it's synostosis. But you are absolutely right. Ahmed obviously has been doing orthopedics a little while because he knows the answers and I'm very impressed. He's been around. So for those of you who don't know what we're talking about, but this bone bridge, right, this synostosis is where the radius and the ulna actually join together. And the reason that happens is if you have too much instability, if you try to manage this non-operatively, then there'll be too much movement and it starts throwing off callus, and it creates heterotopic ossification, which is basically the ossification of the soft tissues around the radius and the ulna. And it really is a nightmare. There is no good treatment for it. Once it happens, the only thing you can really do is try to break it apart and maintain the movement. And it really is a nightmare. I've seen it only a couple of times. And I'll tell you that we really, we all shudder when we see this kind of thing because it really is terrible. Because A, this is in a really young patient, and B, with a radius and ulna that are completely joined together, you cannot have any pronation or supination. It is not possible. So they end up just completely stuck. It's not that they're stiff. They are rigid. They are completely stuck in one position, which is a total nightmare. And again, these tend to be on the dominant side because people usually preferentially will lean out and try and break their fall with their strong arm, with their dominant side. So it's a total nightmare. So how do you get around that? Well, you can't stop heterotopic ossification from happening. You can't stop synostosis from happening, but you can reduce the chance of it happening by getting a good reduction and having and treating this like an intra-articular fracture. So what do I mean by that? We talked about locking plates. We talked about the use of locking plates in the distal radius, and in general. And the principles for it are absolute stability and an anatomic reduction. Now you need that anatomic reduction because the radial bow and the ulna being straight are required for the pronation and supination to happen. You need an anatomic reduction because without that, the height of the length of the radius and the length of the ulna will not correspond, it will not be correct. And so you'll have problems at the distal radial ulnar joint or the proximal radial ulnar joint. And the other thing is that you can't compress across the fracture unless you have a good reduction. So that anatomic reduction is the first thing you've got to get. And so that means doing an open approach, doing an open reduction and internal fixation with a plate and screws on both the radius and the ulna. Now, in the past, we've tried treating these kinds of fractures with just fixation of one bone, and it doesn't work. We found that it ends up being too unstable, and you end up with lots of callus forming on the other bone. Now, of course, the argument there is that you're doing less surgery, it's less invasive, lower risk of injury to nerves nearby and things like that, and lower risk of infection. And of course, all of that is true. But it's not much use to you if you end up with no function. You need it to work. If you're going to do an operation, then it better at least work. So this is the kind of thing that we're talking about, right? So in this picture that you can see on the bottom, you can't even see the fracture on the radius anymore because it's so well reduced. And obviously there's a bit of metal in the way, but that's to our advantage. And you can see there that there's also a bow on the radius. It is not a completely straight bone. And if you try to make it completely straight, then you are mal-reducing it. Now on the ulna, there's a tiny little gap, but I would argue that ulna is basically completely straight. It could have been made a little bit better because there is a little bit of a bend, but that's life. Now, how could they have made that better? Well, they could have made it better by pre-bending those plates. Now, we probably will need to do, but for the people who are just kind of orthopedically inclined, it's probably worthwhile doing a basic science session just to talk about that kind of thing. But if you imagine that bone at the moment has a little bit of a bend in it, if you look at the plate, it's completely straight. So why have you ended up with this little bit of a bend when the plate is completely straight? Well, it's because the bone has a little bit of an arc to it because the proximal end and the distal end are just slightly wider than that middle diaphysis. So you've ended up in this position where you've kind of created a bit of a problem there. Now, the way to get around that is by pre-bending the plate, and that will also compress the fracture away from the plate. So where the tips of the screws are, that end that's closer to the radius, the radial side of the ulna, you can imagine that if you had bent the plate, you could have compressed that side as well. Well, they didn't do that, and unfortunately, they've ended up with a slight malreduction. It will probably be okay, but ideally it shouldn't look like that. This is your best option for avoiding heterotopic ossification. Now, the other thing that you can do is, I would say to you, all right, if you're going to put those two plates on the radius and the ulnar, what's your approach going to look like? Well, if you wanted to, you could do one cut and go at both bones via different windows, but make one cut in the skin and go to both. You can do that, but that increases the risk of heterotopic ossification. So what most people do these days, the way that this is commonly treated, is you'll do one incision from the volar side. It's essentially the same approach that you would normally do for a distal radius. It's called a Henry's approach, but you just do it a little bit more proximally, right in the middle. And you go down and fix the radius, okay? And the mistake people used to make is that they would use that same window to then go and fix the ulnar. But then that creates a higher risk environment for heterotopic ossification to happen, and you end up with synostosis as a result. This bony bridge that we were talking about. So the way that we treat it now is that we make a separate cut over the ulnar, and you can feel on your own forearm that your ulnar, right in the middle of your wrist, right in the middle of your forearm, is almost subcutaneous. It's right there. You can reach it so easily. So just making a cut there and putting a plate on the ulnar completely separately is probably a little counterintuitive, because you normally try and fix everything through one incision. This is one place where you don't want to do that, because they will end up fusing together more commonly, and it's just a total nightmare. So, okay, so the kind of plates that we're using in this sort of situation are called direct compression plates, and they are not they're not just it's not just a simple third tubular plate that you might use in other parts of the body, particularly in the ankle, things like that. Although people do use those, they will not actually compress. These are designed to compress. And the way that they work is they've got these funny shaped holes. And you can see here, if you look at the plate that's on the far left, there are essentially two overlapping holes. Now, the smaller one of those is a locking hole. That has thread. If you put a locking screw into that hole, it will lock into the plate, just like those pictures I showed you before, where all the screws and the plate all behave as one thing. And that's great. Okay. But what about this weird other, like, sort of egg-shaped part of the hole? Well, that is actually designed to pull the plate along. Okay. So it works a bit like this. So you can see the fracture here, and they've put one screw in, and that screw is right in the center, and that is a locking screw. That screw there's a non-locking screw that has just compressed the plate down onto the bone. So it's basically reduced the plate onto the bone. Now, the second screw that you can see this guy driving in at the moment, where the screwdriver is actually in and they're turning it. Now, if you look just underneath, you'll see where that screw has been placed within the hole. And the fact that it's what they say eccentrically been placed, like it's towards the edge, means that as you tighten it, it will start to slide the plate towards the left. As the screw goes down, it will drag the plate to the left, and therefore drag the two fracture fragments together and compress them. It's a bit of a difficult concept to maybe get your head around. But that plate is designed specifically for this reason. It's designed so that as you turn those non-locking screws, that the plate will slide along to allow the screw to go down. The screw head is wider. And so when the screw head starts to engage, it will push the plate further and further to the left. And that compresses the fracture, which is exactly what we need from an intra-articular fracture. We need it anatomically reduced, and we need the force to be applied across the fracture at 90 degrees to the fracture line so that it will heal. So these are the kind of plates that we use in this situation. And this is a closer look at how it works. So as you put the screw in, it will eventually start to engage the plate, and the screw itself will start to slide down further and further into the hole, and that drags the plate in. So you can see here on the right, on the very far right, you can see the difference between the screw as it's going in versus when it is in. Those two pictures of the screw kind of superimposed on each other. shows what it looks like when you're turning the screw and pushing it down versus when it is actually down. When it's actually down, it sits in a different part of that hole. And that small movement, that few millimeters, is the compression that you need. Now, you're not using that to reduce your fracture. Your fracture should be reduced anyway. You're only using this to generate force. The force is the compression across the fracture site, and it needs to be at 90 degrees. So, okay, another tricky one. So same kind of demographic of patient. Okay, exact same kind of patient. Still sort of like a young, maybe 12, 11-year-old, like younger adolescent. And they've ended up with not a both bone fracture, but something else. Does anybody know what this is? So it's not really a distal radius fracture that's like the ones that we've seen. So we've got one answer, Montesia. This is not a Montesia. What's the other one? You can use the name if you want, or you can just describe it. I will tell you that this is a distal third radius fracture. And you can also see that because the radius and the ulna create this ring, there's been another sort of place where there's an injury, but it's not a fracture. There's a distal radial ulnar joint dislocation. This is a Galeazzi. You've both spelt it wrong, but that's fine. I'm happy that you're answering the questions. That's better. So this is a Galeazzi fracture. Now, the radius and ulna behaving as this big ring requires there to be, if there, an injury in one place, then there's going to be an injury somewhere else. And here, it's sort of similar to the forearm, the both bone forearm fracture, except that you've only got one fracture, and the other break in the ring is a ligamentous one. So it's the distal radial ulnar joint that's been damaged here. Now you can see, if you look at that X-ray on the right-hand side, you can see that the ulna has poked right up towards the carpal bones. There you see, there you go. All right, good. Well, I'm glad some of you guys have seen this before. It is not that common, but I think the place where people go wrong with these kinds of fractures is, now look, the one I've shown you is obvious. All right, the fracture's really displaced. The distal radial ulnar joint is totally off and completely dislocated. Fine, okay. But there are some fractures like this where you just see a single bone fracture, a sort of a distal third radius fracture, and the DRUJ looks okay. Well, DRUJ is not okay. It is not really possible for you to get a fracture like this with that mechanism without having another injury. So you have to make sure that with this kind of fracture, you're getting X-rays of the entire radius and ulna in their entirety in one shot. Some places they'll try and piece it together with, okay, this is the distal radius, this is the middle, this is the proximal end. Don't do that. If you can, in your department, try and push for them to just get it in one X-ray, because then you can really see what the relationship is between the radius and the ulna, their relative heights, their relative lengths, the DRUJ, the proximal radial ulnar joint, all of it, the radial head. These are the things that people miss, and the outcome of this, if you get it wrong, is really bad. And the way that people will get it wrong is that they will just fix the radius and completely forget about the rest. Now, look, in this kind of situation, there will have been some movement at the DRUJ. There will have, definitely. Okay, even if the X-rays don't look as bad as this, there will have been some. Now, that doesn't mean necessarily that the DRUJ needs to be fixed. Because in this kind of X-ray, where it maybe doesn't look as bad as this one, the thing that you will see done many times is that people will go and put a plate on that radius, and they'll say, okay, that's it, the job is done. But that is not the end of the job. Once you've fixed it, you have to then, on the table, while the patient is still asleep, check the stability of the radius, of the DRUJ, and make sure that you don't also have to fix that. So you have to be ready to do it. So that means fixing it with a plate, do it with an open approach, fixing it with that direct compression plate that I showed you already, which is fine. We know how to do that. Okay. But after you've done that, once the radius is now out to length and stable, and it looks like the ulnar variance has gone back to normal, that's when you have to then check the congruence of the joint in pronation and supination and physically examine the DRUJ and see if it's unstable. Because if it is unstable, then you have to fix it with K wires, which should drive from the radius into the ulnar distally. And that is something which, again, is a common cause for litigation. Common relatively, as these are not super common injuries. So this one here, now this is a Monteggia. Now you answered that one already, so I won't ask you. But this is a Monteggia, right? So this is a proximal ulnar joint with a dislocated proximal radial ulnar joint. So the radial head is dislocated, right? The proximal radial ulnar joint, that annular ligament, that's gone. The head of the radius is completely out and it's up, sort of trying to get towards the biceps. This is a Monteggia, and the way that I usually try to remember this is Mugger, M-U-G-R. I learned this at medical school, and I don't know why, but it's stuck in my head. I don't know if you guys use the same term, but it's a very English phrase to say that you got mugged. So a mugger is like someone who's trying to take your money, right? So that's M-U-G-R. Monteggia is the ulnar that's fractured. With a Galeazzi, it's the radius that's fractured. I still have to use that. Even now, I've been doing this for ages, and I still have to try and remind this. I still have to use this sort of aid memoir for myself. So the take-home message I want you to remember is not really so much the complex cases, but it's really just that if somebody does ask you, catch-22, all right? If somebody does ask you, well, what is the radial inclination supposed to be like? What is the radial height supposed to be like? Okay, 22, all right? That's your answer. But really the take-home message, less than that, is that you must talk to your patient. This is the most important part. You have to talk to them. If you just treat the x-rays, you're going to miss stuff. If you just treat the x-rays, you're going to do operations for patients who don't need them, and you're going to not do operations for patients who do. The breakdancing granny is not going to get fixed, and the builder who's smashed up their wrist is going to end up with the wrong treatment, and the person with the open fracture is not going to get the right treatment. The importance of a physical examination and a proper history is really, really vital. Okay, thanks everybody. Any questions that I can answer about any of that? Now is the time.